The content shared here is for informational and educational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. If you are experiencing a medical emergency, please call 911 or contact your local emergency services immediately. Today's episode is a continuation of our previous episode, and I have our special guest, Tom Wright, here again. He is with the Nampa Fire Department, and he's going to answer some more questions for us. So thanks for being here, Tom.
Yes, thank you.
In the last episode, we talked about just preparation and documentation that you need and safety considerations and what to expect during a 911 call. And today we're going to talk about during the emergency response. Tom, what should people expect from EMS teams on arrival for a disability or illness-related call, including assessments, questions asked, and decision-making about transport?
The most important thing that our crews, any first responder is looking for is life threats that they have to intervene or address immediately when they walk through the door. So sometimes I think, and this is from my own experience, people get the feeling like we're not fixing their problem, at least rushing in to do something immediately, but I'm trying to gather information so I take the correct road. And so every first responder, the first thing we do is walk in is just assess the scene. We're looking to see if they're breathing. How are they breathing? Is it efficient? Are they awake and alert? Are they tracking me when I walk in the room? Because that tells me, okay, they're doing okay. I can take a couple minutes to ask questions and figure out what's going on before I engage with the patient, or maybe I have to engage with them to get the information I need, but I can take time to do a thorough history and physical at that point. If we walk in the door and we don't see them tracking us, they're not breathing really well, their color is bad, especially if they're blue, we are not going to ask a lot of questions. There'll be a couple very pointed, direct questions that we're going to want to know. And we are going to address to start managing whatever we feel is the problem in that moment to get them stabilized. And then we'll start our history and physical. So I think sometimes there's a misconception that we are going to just jump in and do stuff. And we walk in and start asking questions and tend to sit back a little bit. And sometimes people get annoyed with us because we're not fixing it, or we're not just rushing them to the hospital. It's like, well, let's take a minute and figure out what's going on so we get the right resources and put you in the right spot. And I want to make sure we're doing the right things for that patient, because sometimes moving somebody, I could create worse problems than if I take a second and go, oh, we have to do it in a certain way because of their medical history or conditions or whatever else is going on. So I think that's the biggest thing, is just understand we are looking to address life threats immediately. And if we don't see any life threats, then we are going to want to step back and really just get, especially with a chronic illness or injury person, we want to get a good history of what's going on so we can pick the right treatment path. And make sure we're going to the right facilities, right? There are certain things, if a patient is a veteran, there are certain things the VA cannot handle. And so I know if they meet these criteria, we have to call the VA to tell them, hey, we have a VA patient, but here's what's going on. And they meet the criteria to go to a stroke center, a STEMI center, right? A trauma center, whatever care that they need that the VA can't provide in your local town. We have to get that approval so that they can get paid and get their care taken care of. But then we can navigate to that normal, what I say normal process that we do for somebody that's not a veteran, right? But a lot of our chronic patients, there is stuff like hospice. And if somebody's on hospice, we need to make sure that the hospice nurse is aware of what we're doing. Because if we just transport them, it creates all kinds of nightmares in the hospice system about payment and authorizations. And we need to make sure they're included in that decision making so they could either be removed from hospice so that their care can get taken care of, or we're going to treat them within the hospice system then and leave them in their home. And that's a decision that we need to include family, the patient, and that staff with.
Mhm. So hospice patients really need to know that once they're transported, they are no longer on hospice, and then they need to be readmitted to hospice. Is that
Correct. What ends up happening, so if if the 911 call is for the reason that they're on hospice, the hospice may choose not to have us transport them because it's within their diagnosis, within their scope of what they're managing. But what we've seen is sometimes maybe that person's in there for a cancer diagnosis, end stage cancer diagnosis, but they were reaching for a glass of water and fell out of bed and now have a broken leg. Well, that broken leg isn't part of their hospice care. But in order to get that broken, but hospice agrees they can't fix the broken leg. You don't want somebody laying in bed in distress with a broken leg. So they have to technically discharge them from hospice so that we can transport them to emergency room to get their leg managed by an orthopedic guy. And then they come back home. And when they get home, they get readmitted to hospice. Now, readmitted to hospice, most of the programs, and you may have more experience. I don't have a ton of experience with the readmission process, but most of the nurses tell us that because they were already admitted, once they get back, it's kind of a streamlined process to get them back to where they were.
Mhm.
So it's not a big deal. It's not like you lose your spot. You don't not have care. They will take you back, and there's a streamlined way for them to get them back into the system. I cannot comment on how efficient or inefficient that part is because I've discharged, I've helped discharge a lot of people to take them to a hospital, but I have not been part of the readmission process.
I never had to do that when my husband was on hospice, so I don't know. But I do know that the hospice team generally is really good at taking care of all of those things. So I can imagine that it would be not as challenging as you think it might be.
Yeah. We run into some different hospice providers. So some of them are way better than others, like anything you deal with in life, right? Some organizations are better than others or more efficient. And there's a couple hospices in our area that are just amazing and awesome, and I highly recommend them. And then there's been a couple that we've had some challenges in managing care with them. And they may not be as easy to contact, and I feel bad for patients. Um, but uh, remember when you're picking, I guess my point is remember when you're picking a hospice, you have the ability, your doctor might say, hey, I recommend this one. You have the ability to shop a little bit. Take a second. I know it's a hard decision. It's a hard decision to go on hospice to begin with. Take that second and look at some of the providers and what they can offer. Just don't take the first one that's you're like, here, this one's next up on our rotation. Just take them. Take a second to look at what fits you and your family, and do you get along with that hospice and the providers well? Um, they'll all come out and do a quick assessment. Usually it does not cost anything. And it gives you a chance to meet them, see their programs. And if you look at two or three, you can pick the one that you guys, your family and the loved ones all feel like they fit in with better.
Mhm. I think
By
that's
doing
great.
that, you have a better outcome and a better experience.
Yeah, I would agree with that wholeheartedly. We used home health for probably about 12 years, and it I shopped around for home health agencies just because, like you said, some are good, some are not so good, and I finally found a really good one and stuck with them. And then when it came time for hospice, I just went with that agency because they'd been exceptional to deal with as home health. Okay, here's a question for you. How do responders handle a caregiver who might be a little bit stressed out or having their own health issues when they're not the reason that emergency services has arrived?
That can be a challenging, it's a challenging position for everybody. There as a responder, you have to remember that this is, and sometimes I have to admit, even myself, over the years, you are so used to going to emergency calls that it's almost routine. And there is times that I had to remind myself that, oh, this is this person's worst day, and I need to have empathy and understanding, even though I'm like, hey, this isn't that big a deal. Like in my view of the situation, I'm like, there's a lot worse out there. This is not a big deal. But for that person, it is a really big deal. So our guys, and I'll admit, 3 o'clock in the morning after a rough, busy shift, sometimes you have to dig for those, and sometimes there's a challenge on our caregivers' part, along with nurses or any caregiver to be able to, okay, I got to dig deep and do this. And so, yeah, there are occasionally conflicts that pop up in those moments. Generally, everybody seems to be pretty reasonable about, at least in our world, one of our responders is able to be in a better spot than maybe another, and we switch providers to help deal with that. One of the other methods we use is our sometimes one of our captains or one responder will pull that uh, care provider aside, get them out of the room so that our providers can be doing an assessment, try to figure out what's going on, and then they're giving individual one-on-one attention to that person that's also in the crisis moment, as they're um, breaking down sometimes, right? I see this a lot with loved ones that are caring for especially terminally ill or chronically ill patients, where they're almost at the breaking point of being able to manage them on a daily basis. And like they're almost making a worse scene in the moment or making things worse in the room. And so by us having one of our providers pull them into another room, get them refocused, be able to get some information, let them be heard, let them take a notch down, maybe just sit down, chill out a little bit. Sometimes they've even held hands and just said, hey, just talk to me about what's going on, and just get them away from that and allow them to have some interaction. It definitely levels out the tension in the room, or at least allows the scene to be managed while other people are taking care of that person. Somebody is actually taking care of that caregiver, especially a family member caregiver is probably where we see it the most. Um, and yeah, and then we're able to kind of get back on track and get information. The biggest thing that we also work with our providers is to give them resources to try to, we have a couple contacts of numbers that can get help to that care provider. Sometimes it is, and it's a hard conversation sometimes, but hey, have you have thought about home health? To give yourself a break as a care provider, as a family care provider, you're so 24/7 attached to this situation that sometimes, hey, maybe we bring somebody in for a couple days a week and they're going to hang out while you get to go shopping, or you get to just step away for a second knowing your loved ones. We kind of offer those suggestions and have contacts for them. I would like to further build that out. It's a challenge between all the different agencies that are involved in home health care. But I would love to be able to somehow have, and I think we might be on track with this with one of our local hospitals, but a social worker that could help interact in those situations. So our guys could recommend to the social worker, and the social worker can then kind of help them navigate that system and get them the help they need.
That's a great idea. And I love that the care that what and I saw this a lot, the care that was provided in our home every time I called was for my husband, but I always felt supported by the team too, and had words of encouragement to me. And I was so burned out. And I know a lot of times we saw the same guys over and over again. And I can imagine how burned out they got coming to our house, but they were always so great and always very appreciated.
I think most of our guys in a chronic illness type situation has a they don't get as burned out as you think on those calls because they have a little more empathy. Um, and sometimes it's harder on them because they witness the decline over the years. There are some people that we get involved late into their decline and we don't ever see them in that stronger state. Illness, a lot of cancer stuff, we end up occasionally involved early, and then as it goes on, you get more and more involved. And it's challenging for our crews to go through that with the family. And there's, I think, a lot more empathy and understanding of what the family's going through because of that. I don't want to say sharing the journey because they're not sharing, but they are experiencing parts of that along with the family.
I think it's amazing what you guys do and how you show up for the people in the community.
That is one of the things that I really appreciate about our department and our culture that we've created within our fire department. I think a lot of fire departments are the same, but I've worked at quite a few departments, and one of the things I really appreciate here is the amount of effort that our guys go to take care of our citizens. It's incredible.
Mhm.
I in the transport world, I was in that for a long time, right? I just show up, I do my immediate care, I throw them in the ambulance, we go away. But our fire department will stay behind and clean, like an older lady. We've had a couple of them that fell. I know early on in my career, lady fell. We got her head bandaged. We got her taken care of. Got her in the ambulance. Ambulance took off. My captain's like, "All right, let's go clean up." And I'm like, "What?" He's like, "Let's clean up. You don't want your grandma to come home and have to clean up blood from the hospital. She lives alone." And I was like, "Ah, you're right." And yeah, so we went in, and I mean, we didn't do the best job, but we got as much of it up as we could, got her rugs in the laundry. So at least she didn't come home to a bloody nightmare mess that her family had to clean up. They could just take care of her. And that is the culture we install in our recruits right on through till our guys retire. Every one of our guys think like that. It's truly amazing.
I love that. Okay, I have a question that it might seem really obvious, but it was not obvious to me at the time. And I think a big part of the reason things were not so obvious to me is because my husband was young. He was only 50 when he died, and he was 25 when he got sick. So we're dealing with all these things that usually happen to older people. So I am so glad that someone from your fire department actually told me this, but they said, if he falls, you should call 911. We can come out just to pick him up off the floor. Do not do that yourself. And same thing with, I had to get him to the emergency room. I knew that I was going to be able to drive him, but I have a shoulder injury from caring for him. So I called 911 and said, I just need help getting him into the car so that I can get him to the hospital. So, can you talk a little bit about that and why it's important to call for help in those situations rather than trying to do that yourself?
Think you just said it with your shoulder injury. You as a caregiver, if you're hurt, we teach this in Recruit Academy too. If you get hurt and become part of that scene, you're not helping, you're not fixing, you're making it worse. So taking care of ourselves as responders and as a caregiver, you have to take care of yourself. And realistically, one person trying to lift somebody, I don't care how strong you are, you're still at risk of a back injury. They're people are not an inanimate object that you can just grab and lift up easily. They flop, they move, they become dynamic. They while you're lifting them, that weight changes and distributes differently. And there is a high chance that you're going to get hurt if you're doing it by yourself. So the one thing we don't want to see is somebody who is already a home caregiver get hurt. Because now what ends up happening is that that person ends up having to go to either a rehab or a nursing facility while while the caregiver, the home caregiver, it gets rehabbed and treated themselves. Because you can't always get home health to come into that house. And so that creates a really unstable, not favorable environment for anybody if that caregiver gets hurt. So all of our guys recognize that, and we really would rather have, hey, let's just come out. It takes us a minute to lift you up, and we got two or three of us. We have some extra tools. We have lifting straps. We have different stuff to use that can help us move that person without them getting hurt or the caregiver at home getting hurt. Um, and so we really, rather than having two people in trouble, it's better just to have us come out and do a quick lift assist. And our guys don't mind coming out to help move people into cars to go to the hospital because the paperwork is super easy on those versus we're trying to get him to the car and he fell and hit his head. That paperwork is a lot harder for our guys. So truly, we'd rather be like, hey, we'll help you get down the stairs and get in the car. That's nothing. And we're back in service. It's no big deal. And nobody gets hurt. So that is a way better. And I hate to say it, but an injury to somebody who has a chronic illness sometimes can be the beginning of the end. And it's not what any of us want, right? They could have another 10 years of great quality life. But if they break a hip or get injured with whatever's going on, you can shorten that lifespan pretty dramatically because they can't get up and move. And they have bad effects that come from that. And so we would rather prevent that from happening. And I think all of our guys recognize that.
So it's better to call than to feel bad about having to call.
Yes.
Uh,
Way better.
okay.
Way better.
I
So I will tell you, there is a point where our guys are like, hey, we're going here 2 times a day, 3 times a day. Then they're going to start having a discussion about maybe you need home health. Maybe you need, if it's just once in a while, like, hey, we have a doctor's appointment and I can't get them down the stairs, and it's once a month, our guys are totally game on for that. But if we're starting to go out all the time, then we go, hey, maybe you need additional resources. So there is a line where we start going, hey, there's home health, hey, there's this, and we start opening doors to get that.
Mhm.
And that is a hard pathway to go sometimes. And I've been working a lot with our crews to try to figure out a way to navigate that system because right now we have, and I think it's because we have a older population in our area now, and we're seeing more of this. But we have a group of people who are in that 50 plus, 60 plus that are trying to maintain their independency, but they're starting to fail and can't be independent. And there's a hard challenge to how do we get them the help they need without putting them into a home and making them feel completely inept and unable to take care of themselves. And how do we get that home health that's going to be there enough that doesn't bankrupt them at the same time, right? That works within their insurance. And navigating that has been quite a challenge. So we've started a telehealth program that allows our crews to be able to get to a provider that can start help recommending some of those and get with their primary care provider and get the appropriate resources ordered. And by ordered, there's a doctor's order that creates that, which allows insurance to help cover that cost and gets them into programs to help them. And we're really working hard to try to develop that right now. Because I don't want to see people lose their independence because they're losing their ability to move and get around. I think of myself as I'm quickly reaching those kind of parts in my life where it's like, oh, I could see this happening. Like, how do I navigate that, right? Without completely losing my independence, but still have the ability to help. And
right.
I'm hoping those we can develop better systems nationally. Uh, we're trying to do it locally. I think every place in the country right now is talking to other EMS chiefs have the same issues. And we're all trying to work towards how do we locally fix this problem. Um, and I'm hoping that we'll come up with some better solutions in the next year or two.
I think it's amazing that you're adding that onto everything else that you already do, but I can see how it would make your jobs easier. And something that I think a lot of people don't realize about home health, they think about it for medical stuff, conditions where you need someone like a nurse to monitor, but home health has occupational therapy that can help you set up your house in a way that works better for you so that you can get around better, you can maintain your independence. And they have physical therapy, speech therapy, all of those things.
To go along with that, one of our local hospitals is just over a year ago opened a new program called Hospitals to Home, and a patient has to meet a certain criteria. It can't be just anybody. It has to meet the certain criteria. But they technically are admitted into the hospital, but they stay in their home. And they send care providers out to provide a bed, um, fall prevention in their house, get everything taken care of. They have telehealth visits like every 6 hours, I think, with the nurse check-ins. They have community paramedics who are specially trained in being able to do not only assessments as a paramedic, but able to do some of those home health and kind of a bridge between those that go out and help them in their home get adjusted, take care of them, do bandage changes. The therapy comes out to their home, and that program, which we were all somewhat skeptical about when it first came out, has been amazing and showing great potential for healing people quicker in a better environment with less exposure to, right? That if you want to get an infection, the best place to go is the hospital because all the worst infections are there. And if you're already compromised, going into that environment is a high risk for you. So keeping some of those people in their own home without exposing them to that has been a great amazement. I think that's something that we're going to see in the future grow.
That is really cool. I love that. I love that.
It's yes, it's amazing, and it seems to be working really well. So
Well, let's move on to post emergency and follow up then. You did talk about the talking to caregivers about home health when you recognize that they're burned out, but are there any other programs or resources that you offer to caregivers or that you can recommend to caregivers?
I tell people to contact the social workers at the hospital because they have all the contacts and they know each one of those programs that they could get somebody enrolled in. And a lot of the physicians now or physicians' offices are really good about, hey, you're taking care of this loved one in this condition. Here's some things that can help you. And they're giving out some of those just groups. They meet like once a week, sometimes online, sometimes they're in person. But I strongly encourage anybody that's taking care of somebody like that to get involved in those because you think you can do it on your own, but you can't. And you need that community. And you need to understand that there's other people. You're not on your own island, that there is other people out there. And by talking and meeting those people, you get to learn how to work within the system and be able to, oh, I didn't know that service was available, or I didn't know how to get a hold of this, or are you serious? They would do that for me. Some of those kind of things you find out by being parts of those groups.
Mhm.
Um, and I think that's huge because as a caregiver ourselves as first responders, we have to make sure we're taking care of ourselves in order to take care of our community. And if you're taking care of a loved one, you have to still take care of yourself. You can't just give it all to that loved one, um, because you're going to break down in the end. So we need to have you doing strong, right? And be stable and be there for your loved one.
Yep. Self-care is something that I advocate for all the time. That's the first thing I always ask a caregiver when they call me and they're stressed out. I ask them, what have you done lately to take care of yourself? Because you're right, that is so important. I would not have made it all those years as a caregiver had I not been taking care of myself.
I think that's probably one of the more important things for somebody that has somebody at home that they're trying to manage. And I know a lot of people, even myself, would feel guilty, right? Because you're like, I shouldn't go take care of myself. My loved one's still suffering in this or whatever they're managing. And you have to take that minute to step aside. I see that in our young recruits that they're like, no, I have to be at work. I have to do. It's like, no, you need to take time for yourself too, and make sure you're in a good spot because
Mhm.
you're not going to help others if you're not in that right spot.
Yep, that's very, very true. Are there any common misconceptions that you encounter from the public about EMS responses to medical calls? And if so, how can we dispel them to better prepare people?
That actually is a good question, and we do run into that a lot. Um, and I think it is changing now. Earlier on in my career, paramedicine, you gotta we got it, and I don't want to step back too far, but paramedicine really started in the 60s, 1960s, right? So we're pretty established at this point, but we're still pretty young when it comes to a medical profession. You look at physicians, right? They've been around hundreds of years. Nursing had 1900s, right? Like they've been around a long time. And these professions are pretty well built out. And paramedicine or paramedics is something that um, is a relatively new thing, and people are adapting to it. I don't know as they really know what to expect. Most people are like, well, just call 911, they'll fix it. But they don't really know what that means. And so to some people, they're totally open to what we have to do. To other people, they get like, hey, shouldn't you just take them to the hospital? Hurry up and take them to the hospital. And it's like, hey, we're going to do everything the emergency room can do. Let's do it here in their home and get them stabilized. And they are going to have a better chance at making that drive to the hospital versus somebody we just race in, throw them in the ambulance, and next thing you know, they're declining and we're not able to get them back by the time we get to the hospital. So by us intervening quickly and making a difference in their outcome is really awesome. There is a balance with that because there is some studies that show, especially in trauma, not we've talked a lot about um, a long-term illness kind of thing. In acute trauma, where somebody needs a surgeon to fix a bleed in their belly, yeah, you don't want to sit on that scene very long because they really need to be in the operating room where we can stop that bleeding, right? And so our crew's recognizing when it's time to race to the hospital versus no, we got time to help manage them. And a lot of our medical people we can manage on scene and do the same care as the ER is giving and get them stabilized and get them there for a better outcome long term versus the ones that are no, we just need to really get them into, uh, they need this one treatment. A cardiac or a heart condition, right, where you're having a heart attack. We recognize now that if we get them in the cath lab within an hour, we can almost reverse that and they leave with almost no deficits which is amazing, right? When I first got into medicine, a heart attack was a heart attack, and you were probably going to have a cabbage, a bypass surgery. And then you're dealing with whatever you're dealing with, which was a lot of heart failure patients that then I got to go see once a week or once every other week, or right as they dealt with this chronic condition. And we rarely see heart failure now in the field because of the cath lab. So, but our early recognition, our identifying that within 5 minutes of being on scene or less, sending that 12 lead, getting that team activated. Now, when we show up at the hospital, we're not going to the ER, we're going direct to that cath lab and they're getting their stent placed within less than an hour of the onset of their chest pain is huge. So, a lot of those things we can really help with people. And I don't think people really understand some of that. The other big one is strokes. Um, when I first got into medicine as paramedic, stroke was just supportive care. It probably was the worse than death kind of experience that somebody could have. And now we're able to, at least a thrombolytic clot, right, that's caused by a clot in an artery that's plugging that artery, they can go in and pull that clot out of their brain, and they leave up to 8 to 10 hours after symptoms started, and they can leave the hospital with almost no deficits. Speech comes back, movement comes back, like they're doing great. And that is something that's amazing that we can recognize, call that team in early as a pre-hospital and bring that patient to that lab and get them fixed way faster. And it's amazing the outcomes that they're having. So there's a lot of things we do in EMS that is now, I think we've identified that we can really help people. We can stabilize blood pressures better than we ever had before. We have advanced airway stuff that we've never been able to do in the past that we're really getting good at now. And getting patients to the appropriate provider and the appropriate center is huge. And EMS is pivotal in making those decisions on where they go to get their best care. Racing them to the local hospital may not be the best care for them. The best care might be us starting care and transporting them to a center that's 30 minutes away, but has that specialty care, and they can get treated better.
Mhm.
And so those are a lot of things our medics are asking questions. They're doing that history and physical, trying to figure out, when I say the best resource, where do we send this person, right? Is the local hospital in your small community the best place for this person to go, or do they need that specialty care in a different spot? And sometimes that child, right? We talk about children. We have a child trauma center that's in downtown Boise, our next city next to us, a larger community. But if that kid has a cut, does he need the trauma center? Or can the local hospital handle that one, right? Versus, oh, the cut's in his hand, maybe we'll take it to the specialty center. And those are things that our guys are trained and able to recommend and make happen for our citizens and our patients.
It sounds like what we probably need to do as care providers in the home is just step back and allow the emergency services to do their job, and they will relay to the care provider what they need to do, what needs to happen. Just treat them as they're the expert right now, and they're here to take care of whatever the situation is.
I would say maybe not completely, because I'm still looking at you. There's a lot of diseases out there, and I might be familiar with all of them, but I guarantee you, as that care provider for that loved one, knows way more about it than I do. So I am looking for you to help me with subject matter expert stuff. And we are going to listen to that care provider that's taking care of that person. I see that more with kids because there's a lot of rare disease kind of stuff we see with kids. And believe me, the parents are way more educated than your paramedic ever will be on that specific disease. So yeah, we need to use that resource. But at the same time, there are protocols and treatment stuff we need to make sure we're hitting. And I go back to life threats. We go back to life threats all the time. And a lot of times we might change and alter what we do because of something that we see as a life threat. Yeah, I think it's a teamwork is really where we need to be. I believe most of our medics are probably as are super receptive to someone that can logically, and I don't want to say clinically because it sounds cold, but right, is able to describe what's going on and what especially with that disease process. Um, it doesn't mean we're going to completely do everything you say, but we are looking for you to be the subject matter expert to help navigate our stuff. And if what you're saying matches with our understanding, then we have an awesome team. If we start contradicting ourselves, then that medic's got to go, ooh, wait, who's right? Where am I going? Maybe I need to call medical control. Maybe I need to get right some other input in there.
Mhm.
So yeah, I think it's a teamwork thing,
Okay.
truly.
So that was pretty much my role. I was there giving all the information because I knew everything that was going on with him. I always knew he was sick before he did. Um,
Usually that is the case.
yeah. but really tried to stay out of the way so that I wasn't in the way of what they were doing.
Yeah, we're going to want to get vital signs. There's a good chance we're going to put them on the cardiac monitor. We need to do a quick physical assessment. You again hitting those life threat things. We want to listen to lung sounds, stuff like that. And then while we're doing that, other people that are responding are helping getting the stretcher ready. Because if we're going to transport, right, they know the next step is here. So let's get it set up and get it ready. So when we say, okay, it's time, we can just move them over and efficiently get out and get them to the hospital. And then that medic doing the assessment is probably going to want to have some good information with the caregiver, along with asking questions to the patient if they're able to respond.
Well, you touched on it a little bit, but has how has EMS evolved in handling calls related to disabilities and chronic illnesses, especially with the aging populations?
That is something that we've changed dramatically since I went to school when I went through my training. My training didn't involve any elderly training, actually specific, other than these diseases tend to be in old people, right? We didn't really touch on the fact that they lose dexterity, the fact that the vision stuff. We barely touched on like macular degeneration and some of those type things, cataracts, and what that does to somebody. Now that is part of our basic training, part of our EMT training, and in our paramedic class, we have units that address the differences and the challenges. Uh, we talk about because some of these people may be infants, right? And with chronic disease, uh, rare disease kind of stuff. And so we focus on how to interact with that patient and the caregivers. We also talk about the elderly population and dealing with family and chronic illness and how do you deal with loved ones, and where do you get your information and some of the ideas of the care that they're getting or needing that is different from our normal everyday patient that we see in EMS. Um, we also are have started putting on fall programs and access to more resources. Um, we have actually three fall programs in our area that involve a physical therapist and strength training, which I think is huge for our elderly population because that's one of their problems is they tend to be more sedentary and they lose that muscle mass. And by them helping them with a little bit of muscle mass, it helps with them movement and keeping them independent longer. Um, and understanding what is involved in that at a paramedic level so you can start recommending and getting people into those resources is something that's been a huge change. Um, and I also think there's been, well, about 9 years ago, we started the community paramedicine program. Maybe it was about 10 years ago in our area. Community paramedic became a thing. And a community paramedic is can be a multifaceted kind of position. We're tweaking them towards some of them are doing a mental health focus on the because we have bipolar people that stop taking their meds that are unique populace in certain areas that we're special training those community paramedics to work with police officers in dealing with that, along with social workers and counselors and mental health people. But we also have a section of them that are dealing with the chronic illness stuff. And they get the ability to write scripts, do sutures in the house so that we're not transporting that person to the hospital. They're getting advanced practitioner type stuff that they can do to help with the care of that person and keeping them in their home. Because the hospital isn't always the best place for somebody that has a chronic illness. There are some times that it has to be there, and that is the right place to get care. But a lot of times, if they can stay in their home, they do better. So by the switch that I've seen was everybody just goes to the hospital to now what's the right thing for this person and how do we keep them in the right the right care for that individual versus no, everybody goes to the hospital, gets evaluated, and then goes to wherever they need to go from there. I think that's the biggest change I've seen now is we actually look at what does this person really need and I hate to use the analogy, you call, we all. That used to be the saying we had when I come out of school. Oh, you call, we all. Let's go. Like just taking everybody to now where we're going, hey, what's the right thing to do for this person? Is the hospital the best place for them? Because the ER may not be the best place for everybody. And maybe if we can get them additional care or that community paramedic to come out or even a telehealth visit that gets them the home health they need or gets a provider to come out to their home might be the better way of keeping them getting the help they need and keeping them healthy in their home as long as we can.
Wow, I love that. More individualized care instead of a one size fits all solution.
Yes. And I think that's where we're going to see EMS evolve to more of a what does this case need? There'll still be, hey, all the level one traumas go to the trauma center. I mean, there's still going to be some of that. But when we're talking about chronic illness and our elderly population, it's more, well, wait a minute, one size doesn't always fit all. How do we get them the right care in the right moment for what they need? We're really looking at more of a telehealth angle rather than just transporting I mean, there's certain patients that are going to meet a criteria that no, you need the ER. But then there's a probably about 25% of our calls right now could be handled through telehealth, a script issued or right, some service provided or referral to a different service without having to go to the ER, which reduces ER overcrowding, which helps for the people that truly need to be in the ER, helps with our stress reduction, right, between our responders and the ER staff, because I'm sure you've had positive and negative experiences in the ER. And if we can get rid of some of that people that need help but don't necessarily need an ER, that and we get them their appropriate resource, I think those people that can now care for the people that need to be in the ER will improve because they're not looking at, I have 30 patients in waiting versus, oh, I just have these 5 people that need help and they need my help. So it's more rewarding.
How much more of a strain does that put on you guys and your resources having to take care of all of those extra things?
A lot right now because we're trying to figure it out. But I'll just clarify that too, is that our guys, one of the challenges as a firefighter, firefighter specific, the paramedics, the ambulance, our transport service, the paramedic service that just does transport is only responsible for EMS and transport stuff. The firefighter has to understand EMS. They have to be either a paramedic or an EMT and understand how to take care of patients. They also have to be really good at firefighting, which is a whole skill set in itself. They also have to understand hazardous materials. They also have to understand technical rescue, how to cut somebody apart out of a car. They also need to understand rope rescue. How do I get a technical, like somebody that's in a confined space area and or a trench collapse because they were building, didn't have the trench secured, it collapsed on the workers. How do we get them out? These are all the skills that our firefighters are showing up with, not just how do I take care of one facet of EMS. So there is a lot of strain on our guys when it comes to now we're adding this layer of how do we navigate the correct care for that patient in the right setting. And that is going to be a challenge over the next few years as we figure it out.
When the fire department would show up, it was just such a relief to have somebody there who could take over the situation for a short time. And I knew that they knew what they were doing, but I had no idea how much they had to know.
It's a lot to maintain training, competencies, right? All those skills in all those different areas. And we don't have some of those areas are one, maybe 2 times, unlike the movies, once or twice in a career kind of calls. They're not happening every week. So yeah, how do you maintain competencies and be good at every part of that and not let something drop? So yeah, there's a lot of challenge for our guys.
I do want to ask. I have several friends in the fire department, and I've asked them all this question. And the answer that they always give me is, we're just doing our job. And I know that that's true. But if someone wants to thank or provide feedback after an incident, what is the best way to do so? And how does that help improve services?
The best thing you can do is stop by the firehouse when you see the guys there and just thank them. There's a lot of people that bring cookies. That's awesome. Especially around the holidays, we all gain weight from it. So, and makes us work out longer, but, we do appreciate it. And we really just appreciate the thank you, um, that people are able to give our guys for what they've done. Um, it took me a long time. I'll be a little vulnerable. It took me a long time to accept some of that thank you from people. Because yeah, I am doing my job. It is what I do, right? And then I also am standing there a lot of times at the firehouse and I wasn't on the call. Like they're telling me, I can totally relate because I've been on calls like that. But I'm like, I don't recognize you. I was not on this call, right? And it took me a while to finally realize that, yeah, I think a lot of people want to thank us. They don't know how. And even if I wasn't on that call, that sentiment or that appreciation, on the human side, which is kind of scary to open up to sometimes for firemen, for anybody, I'll be honest, anybody. But to open up to that human side of things, um, it is challenging, but actually is super awesome and really welcomed. So our guys do appreciate the cookies and cakes and all the crazy stuff that shows up. Um, yeah, there are some people that bring healthier stuff. That's welcome too. Some of it depends on your crew. They prefer the sugary stuff. Some of them prefer the healthier stuff, but, either way, I think just coming by and saying thank you for what we do is awesome.
I never did that. I never went by and said thank you because my thought is always, I'm going to be bothering them. So I never did it. I always made sure to say thank you when they were at our home.
And that is really good for most of us. Yes.
Okay. Okay.
You can tell when somebody's genuinely saying thank you. And on scene, I actually appreciate that just as much as them stopping by the station or interrupting us at the grocery store or whatever. The one thing I did want to say, because we've talked a couple times about the crew coming back and you recognizing people. Most of our guys, when we assign them to a firehouse, unless they get promoted, they stay at that station and on that shift, until that promotion. So when they eventually come as an entry level fireman, maybe they make driver, engineer, driver, then they get moved to a different station or sometimes a different shift. When you get promoted to a captain position, so you're the supervisor of that engine company or that unit, we definitely move them to a different shift and gives them a chance to start fresh as a leader. But those are the only time we really move people. So for the most part, that crew that's going to come to your house, and I think most fire departments are that way across the nation. So that crew that's coming to your house is probably going to be the same guys or the same three shifts, the same 9 to 12 guys that will be showing up most of the time.
Well, I am really curious what made you choose the fire department, and then once you got into it and realized how difficult it is, what was it that made you stay?
It's kind of the cliche for me. I remember as early as probably 8 years old wanting to be the fire department. I lived a mile or so from the volunteer fire department in my town where I grew up. And so I was constantly like running out when the fire engine went anywhere, seeing the guys doing drills. Like I was just infatuated with it and always wanted to be a firefighter. Um, I tested for a long time in New York. New York has a different hiring process than Idaho does. Um, and it's a much larger area. I had tested, there was 800 of us testing for 30 jobs. And on my qualifying list, try to be politically correct, my qualifying list, the last time I took that test, I was really excited because I scored a 98 and I thought, ooh, I got a job and, or I got a chance at a job, and I was 220th on the list. And so I'd kind of given up the idea of becoming a career firefighter. I was a volunteer firefighter since I think 17. I joined the volunteer fire department. So I've been doing that for years, and I was like, well, at that time I'd been a career paramedic for 10 years, working in the city of Syracuse, and running a lot of calls. And I had moved out and took a job with the county where I was a flight medic part-time, 2 days a week on a state police helicopter, and then I'd work the ground ambulance for a couple days a week. And I decided, well, if I can't be a fireman, I just want to do flight full time, and that's how I ended up in Idaho. Was St. Al's hired me, flew me out here, and it was awesome. But once I got out here, it worked a couple years, and there was a older guy down in the um, ER doing his clinical time that got hired for Boise Fire. He was in his probably late 30s, early 40s. And in New York, everything was 20 and out. So if you didn't get hired by the time you were 32, 34, you weren't getting a job. Like, it was very rare for them to hire somebody that was older. Um, so I just assumed everywhere in the country was like that. And so I started giving this guy a hard time because I thought he had like screwed up and lost his license. And turns out he's like, dude, I'm in academy. I was like, what? They hire old dudes? This is awesome. I thought I was old at 34 at the time, but um, little did I know I'd get older. So I went ahead and applied for, and ended up getting hired by Nampa, and had myself in the right position that I could take the pay cut to come onto this job, work part-time, still with a flight service for a couple years. Um, the thing that's kept me in this job that's been incredible is, one, the fire service is a huge challenge. So, like I said, we have 5 or 6 disciplines that are with an all hazard fire department that you have to be good at all of them. You can't just be mediocre. You got to be pretty good at all of them, because when they happen, you've got to be able to respond, act, and do the right things. So there's always this challenge of trying to keep up with all those different disciplines and be good at it. But the number one thing that kept me with Napa, with my department, is the people. Um, the culture we have as a family, we have a fire family, and it's truly that. Our department is growing, and that family has gotten huge, and it is harder to keep that tight group. But when I first got hired, our shift did stuff. Families all got together on our days off and did stuff. We did stuff as groups all the time, and that connection with those guys that were having similar experiences as me, and knowing that I could talk to them and get through some of it. In later years, I realized some of the therapy we did may not have been the best at the time. But that connection was huge, and feeling part of something that was bigger than yourself, and was amazing what we did for the community, and the emphasis that our guys put on the community and our citizens, uh, was huge, and I wanted to remain a part of that. I looked up to a lot of our guys that are retired now, and I still look up to them and try to either meet or excel what they did, which is hard because there's some big boots to fill prior to us. And I hope we're installing that in our younger people as they come through with that same idea and concept.
I guess I had never really thought about it as a family environment, but it really would have to be as closely as you work together.
Yes, a third of your life. When I first got on, we were in a different shift, but for the last almost 14 years, we've been my position is different. I work Monday through Friday. But the line guys are working 48 hours. So they work 2 days straight. and then they get 4 days off. So they come to work at 8 in the morning and they don't leave for 2 days and then they go home. And then they get 4 days, and then a lot of times they're picking up overtime or shift trades, helping out other guys, right? So that your 4 day isn't always your 4 day, but you try to take as much of it as you can. It's kind of weird how you have blocks of time that you're literally at work with your work guys, and then you're at home and it's family chunk time. Um, yeah, that was a hard, I have to admit, the hardest thing was going to administration about 5, 6 years ago for me was adjusting to working every day of the week versus having those chunks off.
And then not being around your crew, your regular crew all the time too.
Correct. Well, I have the other chiefs, there's 6 of us and we are our best friends. Like we're all together. We've all grown up in the fire service together. We've all worked in the same department. Most of the chiefs I've worked with online. And we're now running the place, right? We're now the chiefs. So we have a pretty strong group and a good community within ourselves. But yes, it is way different becoming a leader in a chief capacity than being online with one of the guys.
Well, Tom, you have given us so much information to think about. There were so many things that I didn't know. I knew that there was a lot of pressure on our first responders. I did not realize how much pressure there was. And I so appreciate you answering all of these questions for me. And I know that it's going to be very, very helpful to anyone who watches or listens to these episodes. I would like to say a huge thank you to everyone across the United States in our fire department. Thank you for doing what you do to serve our communities, to care for the people in your communities, and personally, the Nampa Fire Department for everything that you did for us while my husband was sick. We spent 10 years calling 911 and having you respond to those calls. And I truly believe that I would not have made it without your help. And Tom, thank you again for taking time out of your very busy schedule to do this with me.
Thank you. I appreciate the offer and the time we had to talk. Thank you.
Thanks so much for listening today. If you're a caregiver, a family member, or just someone who might need to call 911 someday, this is the kind of information I wish I'd had 15 years ago. So please hit subscribe so you don't miss the next one, and share this episode with someone you love. Together, we can help the next family be a little less scared. I'll see you in the next episode.